Thank you for the invitation to speak today about gender-affirming hormones and antiretroviral therapy. I have no conflicts of interest. So first, I'll be talking a little bit about antiretrovirals and gender-affirming hormone therapy, really discussing what the guidelines say, then talking about pharmacokinetics and drug-drug interactions with ARVs and whether there's cause for concern. And lastly, I'll discuss very briefly beyond drug-drug interactions, some issues that you should be aware of as far as lipids, bone health, and cardiovascular disease. So to provide a historical perspective, there's not a great deal of guidance in this area from the transgender health guidelines, despite the fact that transgender communities are disproportionately affected by HIV. The first WPATH guidelines, called HABIGDA, were released in the pre-AIDS era in 1979, just 2 years before the first first case report of a person living with HIV in the United States. In the WPATH standards of care version 6 were actually the first guidelines that discussed HIV and basically said that it was unethical to deny availability or eligibility for hormone therapy solely on the basis of HIV. The United States HHS adult ART guidelines included gender-affirming hormone interactions and ART in 2017. And then most recently in 2019, actually included a complete section on transgender people and HIV. Now, as Dr. Deutsch has pointed out, there are multiple estrogens and androgen blockers used throughout the world for feminizing therapy. And some of these are not recommended, for example, ethinyl estradiol and conjugated estrogens, but they're used in many countries if that's all that's available. For example, in the Caribbean, many transgender women are using birth control pills or ethinyl estradiol along with sapropterin. There are also many different options for testosterone, as you can see, including patches, gels, nasal spray, long-acting injection, and tablets. So this slide shows the metabolism of estrogens and testosterone. The reason for concern about drug-drug interactions is that the metabolism of estrogens mainly occurs in the liver. The first step in the metabolism of estrogens is hydroxylation catalyzed by cytochrome P450 or CYP enzymes, including CYP3A4. And, this is, again, slightly of concern because many of the antiretroviral agents, including the boosted protease inhibitors, ritonavir, cobicistat, and the NNRTIs, are metabolized through CYP3A4, and they elicit variable effects on other medications acting as either inducers or inhibitors of drugs metabolized by CYP. When we look at the international ART guidelines, most of them include the same antiretrovirals as first-line agents, including a non-nucleoside or non-nucleotide backbone with an integrase inhibitor. If patients are using these regimens, then drug-drug interactions are unlikely to occur. To delve into the ART hormone drug-drug interactions a little more deeply, the ARVs that have the least potential to impact gender-affirming hormones include the NRTIs, the HIV entry inhibitors, for example, IBA, T20, and Maraviroc, unboosted integrase inhibitors, and two of the NNRTIs, rilpivirine and doravirine. When using these agents, no dose adjustment of hormones is necessary. Some of the ARVs can increase concentrations of some gender-affirming treatment. Elvitegravir, cobicistat, and boosted protease inhibitors can increase dutasteride, finasteride, and testosterone. And the recommendation here is to monitor for adverse effects and decrease the doses of gender-affirming treatment as needed to achieve the desired clinical effects and hormone concentrations. There are also some antiretroviral drugs that can decrease the concentrations of gender-affirming treatment. For example, the boosted protease inhibitors, as well as efavirenz, etravirine, and nevirapine, can decrease levels of estradiol. And efavirenz, etravirine, and nevirapine can also decrease testosterone and the 5-alpha reductase agents. And the recommendation here again is to monitor for effects and increase the dose of hormones or blockers to achieve the desired clinical effects. There are also some agents that don't have a clear or consistent action on gender-affirming treatment. Elvitegravir with cobicistat and cobicistat-boosted protease inhibitors can increase or decrease estradiol concentrations. And in these situations, it's important to monitor estradiol and adjust the dose to achieve the desired levels and clinical effects. And I should say that these tables come from the US HHS guidelines, and you can access them to get more information. As you may already be aware, hormone therapy can affect lipid levels, impact on bone health, and both of these are areas of concern for people living with HIV. You know, several studies have shown that lipid levels can be affected by estrogen therapy. You know, the studies have been done around the world and include different types of estrogen regimens as well as different types of blockers. So if you look from paper to paper, you may see different results. But in general, estrogens increase triglycerides, but with oral estrogens only. If you're using, for example, transdermal estrogen, there is no change in triglyceride levels. Testosterone used by transmasculine individuals can result in a decrease in HDL cholesterol and can increase triglycerides and LDL. However, the lipids still remain in the desired level, so the clinical significance of these minor changes is unknown. There are also some effects of hormones on risk for venous thromboembolism and uh, cardiovascular disease. So estrogens are associated with increased risk of venous thromboembolism and pulmonary embolism, and this often occurs in the first year of hormone therapy. They usually, women who sustain a DVT, for example, usually have other risk factors, for example, smoking or that they're living with HIV. We also know that ethinyl estradiol carries the highest risk, and this is no longer used in the current regimens. Estrogen has also been shown in a few studies to increase the risk of ischemic stroke. One recent study was done in the United States using um, patients who were members of Kaiser Permanente. But again, the risk of ischemic stroke happened after many years of being on hormone therapy. There are also inconsistent results around hormones and myocardial infarction because the studies often do not adjust for risk factors such as smoking. A recent study that looked at individuals in the United States using the BRFSS survey found that transgender men had an increased risk of MI compared to both cisgender men and cisgender women. And transgender women had a twofold increase in MI compared to cisgender women, but had the same risk of MI as cisgender men. And these findings were adjusted for age, diabetes, hypertension, lipids, smoking, and exercise. So again, I think the takeaway message is there's still much more research that needs to be done. So bone health is extremely important for people living with HIV, especially for those who've been exposed to tenofovir disoproxil fumarate, or TDF, or those who are smokers. Transgender women have elevated rates of osteopenia compared with cisgender men even before starting hormones, with one study showing a 15% prevalence of osteoporosis and a 32% prevalence of osteopenia compared to lower rates among cisgender men. In the United States, osteoporosis screening is recommended at age 50 for people living with HIV, and with a recommendation to consider screening earlier if there's elevated risk, which also includes those who've had gonadectomy without taking hormones. So transgender people, especially those who've had lower surgery, and also gonadectomy, so either oophorectomy or orchiectomy, and who've stopped taking hormones are at high risk for osteopenia. And in these situations, TAF is preferred to TDF. Other things that providers can do is to inform their patients, optimize bone health, for example, exercise, diet, smoking cessation, and vitamin D. Some of the important benefits of hormones also include improved quality of life, reduced stress, anxiety, and depression, and improved social functioning. Hormones also have a beneficial impact on HIV care and retention. Results from a recent SPRINTS initiative actually showed that integrated HIV care with hormones improved retention and viral suppression. Hormones are also extremely important for getting people into care in the first place. So the key takeaway points are that although there may be small interactions between some ARVs and gender-affirming hormones, the first-line agents used for HIV treatment, the unboosted integrase inhibitor regimens, do not really have any significant effect on hormone levels. Boosted proteases and NNRTIs may influence estradiol, testosterone, finasteride, and dutasteride. It's important to measure hormone levels after initiating or switching ART if a drug-drug interaction is anticipated. And people living with HIV have an elevated cardiovascular disease risk. So in all patients, whether trans or not, we should be addressing modifiable risk factors and paying close attention to ART regimens. For transgender women, we believe that transdermal estrogens are preferred to reduce the risk of venous thromboembolism. And lastly, consider your patient's risk for osteoporosis and osteopenia, and you may consider using a TAF instead of a TDF regimen, and also doing early DEXA screening for patients if they've had gonadectomy, especially if they've stopped hormones or are taking low doses of hormones. So I'd like to thank you for your attention.